Um, Dr. Corneliu Luca is a neurologist and clinician researcher in the Department of Neurology at the University of Miami and associate professor of neurology. He has completed residency training at University of Miami Jackson Memorial Hospital and earned a PhD in molecular biology studying mechanisms of neurodegeneration. He has also completed a fellowship in movement disorders at University of Miami and National Parkinson's Foundation Center of Excellence. Okay, let's listen. He is a board certified movement disorders neurologist. So welcome, Dr. Luca, and thank you so much.
Thank you so much for the kind introduction. Really appreciate the opportunity to speak here in front of you. My name is Corneliu Luca. I'm Associate Professor of Neurology at the University of Miami, and I'm here to continue talking about the treatments of Parkinson's disease. In the morning, you heard from my colleagues regarding the medical treatments. What we'll do in the next 10-15 minutes before your break is to briefly present what's the surgery for deep brain stimulation. I'm going to show you a couple of examples and videos of my patients. And actually, I want to say I'm so happy to see a lot of my patients here today. So thank you all for being here. So I think this is very exciting because, as we know, as disease is progressing, as the medication stops working, we do have options for treatment. And one of the most, I think, amazing developments in the field of neurology, I can say it is really the development of deep brain stimulation, which has been around for more than 20 years. And you will see actually this procedure that will be applied to other neurological disorders. We have already epilepsy, essential tremors, and there is a lot of research on other neurological disorders. So what's deep brain stimulation? Here is a diagram actually illustrating deep brain stimulation as a procedure that uses electricity to stimulate parts of the brain in order to restore the abnormal brain circuits to normal. Here is the example, for example, of a battery implanted in the chest, and you will see a wire that is placed under the skin, so nothing is visible outside, and with a cable that is implanted deep in the brain, actually able to help with Parkinson's symptoms. How is this surgery done? At the University of Miami, this procedure has been done for many, many years. Here is a diagram showing the components of the system. You have basically a wire that's implanted in the brain. You have an extension that connects the brain with a battery. The battery is implanting in the chest. And finally, a remote control. Because the exciting thing about this procedure is that actually you're going to have the ability as a person with Parkinson to control your own stimulation. With a telephone or an app, with the remote control, you will be able to go up and down on the intensity of the stimulation, depending on the intensity of your symptoms. So DBS will allow you to actually improve the quality of life. This is a diagram that shows you that as the disease progresses, you have a lot of fluctuations. The levodopa lasts only 2 hours, and then you experiencing an off time, then again an on and an off. A lot of my patients are describing this and as a roller coaster. 2 hours are okay, 1 hour off. 2 hours are okay, 1 hour off. So when you have this happening 5-6 times a day, you can imagine there is a lot of trouble. The medications do not last enough. Then it's the time to talk to your neurologist about considering DBS. If you do the surgery, what basically happens, you will decrease the intensity of this episode. You're smoothing out the severity of the episodes, and overall, you'll increase the total time that you are on. In average, people that have DBS increase their on time with about 4 hours compared to the time that were before the surgery. They're able to decrease the amount of the medication. Some of the patients actually decrease the medication with 100%, and they have effects that are long lasting. Want to say that DBS is not a cure, and I'm telling this because you need to understand that in spite of doing this procedure with wires in the brain, the disease will progress. However, a lot of the symptoms will get better. And I have listed here on the table on the left side the symptoms that actually are getting better. And you can see the tremor, which is improving significantly after DBS, the rigidity, the slowness will get better. There are things that will not always get better after the DBS. Sometimes speech does not, sometimes balance can get worse, and memory. So that you need to understand that DBS improves some of the symptoms, but not all of them. When do you have to do the surgery? Like in everything, there is a window of opportunity. It doesn't make sense to do surgery early on when you're being diagnosed with Parkinson's and when you're doing very well with 1 tablet of levodopa 3 times a day. But also doesn't make sense to do surgery too late, 20 years after, when the severity of the symptom is so big where the chance of improvement are small. So you need to talk exactly with your neurologist about the surgery at the moment when you feel that the medication are not lasting long enough, when you think you need to take the medication, let's say 5 times a day, when you're already on 3 or 4 combinations of medications, when you experience a lot of off time, when you do have a lot of involuntary movement like dyskinesia. At the University of Miami, we do have a multidisciplinary team that evaluates comprehensively any patient with Parkinson's disease that considers deep brain stimulation. We do an evaluation where you come off the medication, and we'll discuss with our team of neurologists if you're a good candidate. You will have to have an evaluation of your memory and your cognition, and having all of this data together, we can determine what is best in your best interest in terms of improvement of the treatments. Who's not a good candidate for the surgery? Well, I'm sorry, who's an ideal candidate for the surgery? My title here is blocked a little bit by this. Let me see if I can move it. Probably not. So the ideal candidate for the surgery is somebody who has had Parkinson for about 4 to 5 years, who has a very good response to dopamine, who has tried multiple medications, but they feel the medication really doesn't last long enough, someone who has disabling dyskinesia, tremors that are not responding to levodopa, or significant off time. If you do have cognitive impairment or significant dementia, we will not proceed with the surgery because we think the risk of worsening these cognitive issues are high, and it's in your best interest not to do the surgery. If you have severe depression that's not treated, if you cannot tolerate the surgery, we will also advise against the surgery. The procedure is done in 2 stages. In the first one, you will have the wires implanted in the brain. This is called typically the stage 1. There is a frame that's placed and with an MRI of the brain done before the procedure. And the second stage, which is typically done in at our university a week later, it's the placement of the battery. So connection of the battery with a wire all the way to the brain. I'm going to show you a video of the patient that is in operating room, and you'll see the effect of the stimulation being turned on. I assume the volume is high. I would like someone to put it a little bit lower.
Can we simulate here just to simulate? Just
Okay, I did myself. This is a patient with tremor, severe tremor. And we have here my colleague, Dr. Mazaleski, that's going to turn on the stimulation in a second. So you see the intensity of the tremor. And here below.
Good, that's expected, right? So I don't want you to panic.
Can we turn on the volume lower?
Yeah, that's actually that's a good sign.
I have to do it myself.
And you're gonna feel it for 5 seconds, and then it's gonna be gone.
And here we go. You're gonna see the hand.
You feel the tingling?
So 10 seconds later, with a click of the button, the tremor is gone. So this is the degree of improvement that you get with stimulation. And I can tell there is no medication that can do this. This example, particular one, it's a patient with an essential tremor, but we do have exactly the same thing in people with Parkinson's. And I'm going to show you next slide another video of a patient of mine who has Parkinson's disease and had deep brain stimulation. Here on the left side, you're going to see him at the first visit when we turn on the stimulation. Let's see if someone turned the volume down. So, no, right now the stimulation is off. Okay, so patient comes off medication. Is the first time we need to turn on the stimulation. You see severe tremors. Right hand. If you come at University of Miami, we'll have you do this a lot of times. It's part of the examination of patient with Parkinson's. And what you can appreciate here is the severity of the tremors in someone that has the stimulation turned off. You will see me turning on the stimulation. So I just press a button on a computer. Currently, we have now new devices that will not require any wires. And actually, this is done wirelessly. And you'll see the patient on 0.8. Correct. Let's see what happens. Okay. So 10 seconds later. Right hand. The improvement in what we call bradykinesia or slowness. Right. Tremors are gone. Very good. Keep the arms up like this. Excellent. Your finger touch your nose. And my finger. No tremors. The other one touch your nose. And we're going to have him stand up and take a couple of steps. Turn around. He's able to do. And quite happy. Here's another example. I mentioned before that DBS doesn't help with everything. It helps with tremors. I showed you the tremor. It helps with slowness. I said it doesn't help with freezing of gait. A lot of time it does, not always. And here's an example of a patient that is off. Here is our colleague, Dr. Hislop, examining our patient. Our patient is in the first session when we turn on the stimulation. In this particular video, you will see a patient where the stimulation was not turned yet. And you probably recognize what we call freezing of gait. Difficulty walking, shuffling steps, and you will see the inability to turn. And my colleague, Dr. Hislop, very carefully protecting the patient from a fall. The same patient. Okay, we're going to turn on the stimulation right now. You see with this little phone that connects wirelessly with the battery in the chest. He walks with big steps. Okay. Vira. It's going to turn around. There is a little bit of hesitation, but remember, he takes no medication right now. So we're able to improve really a lot of the patients, the symptoms of patients with Parkinson's disease with a well-placed lead. And here is the last video of the day. Is a patient of mine who is a pianist, and she was very kind to share this video with me and tell me that finally after DBS, she was able to go back and play piano. sure exactly what area is this, but it's a pretty nice piece. And one more. You guys want more? Okay.
So right now the
This is not
DBS
Parkinson.
is off.
This
Let's
is
try to turn it back on.
essential tremor. So you see the severity of the tremors, and just watch
What do you feel?
her for 10 seconds as the electricity sets in.
Very
She feels a
good.
sensation of
Let's see. Touch your
tingling.
nose. And touch my finger. How about the other one? Good. And the arms back like this.
So I hope you can appreciate the difference
it's back
in
on.
the effectiveness of this procedure. So, is this effective in everyone? The secret for this success is, number one, to have the right patient selected for the procedure and a multidisciplinary team that has experience in producing these results. And at the University of Miami, I think we are very well positioned to ensure the highest chances for you to get better. And that's because we do have experience for many, many years. We have a team of 6 neurologists, we have neurosurgeons, neuropsychologists. We have a really a big team that is dedicated specifically for this procedure. This is a diagram that shows, for example, the rate of complications. This being a surgical procedure is associated with risk. Hemorrhages are possible. At our institution, the risk of hemorrhages is less than 1%. The risk of infection is somewhere around 2 to 4%. In terms of outcomes, we have published our data and have shown that post-surgery, the improvement in the motor scores are at least 50%, and many times this is associated with a decrease in the amount of medication that patient would take. In the last 3 minutes of my presentation, I'm going to show you the 3 devices that are available on the market. Medtronic has been in the area the longest. They have a device that's called Percept that has the ability to sense signals in the brain and help us as neurologists to adjust the intensity of the stimulation. They also have a lead that is directional and allows us to move the electricity in different fields so we can avoid side effects. Next company that came on the market after Boston was Abbott, who launched this system called Infinity, and most recently, actually, they have brought a new platform that allows us as physicians to program your battery remotely. So you can be, for example, at your home, I can be in my office and connect with your battery from a distance. By using this video connection in the same time connection with the battery, I can check the status of the battery and I can do adjustments on the stimulation settings that you would otherwise would not be able to do by yourself, and you need to come into the office. And we have really success with using this technology and a lot of good feedback from patients. Boston Scientific is the third one. They have a sophisticated system that uses both chargeable and non-rechargeable batteries with leads that are directional, and we actually have participated in the research trial at the University of Miami, and we have contributed to the approval of this system in the United States. So there's a lot of options for treatment. I'll end here, and please get in touch with us if you have more questions.